invitation. And thanks to the organizers and Meratis for organizing this course and inviting me to talk. So I was given this talk, classification of distal radius fractures and also indications for fixations. Yeah. Okay, it might be a bit dry for some of you all. But just bear with me because I think it's quite interesting for a lot of us because a lot of us only know about the AO classification, but all the other historical classifications we don't know about. So actually my purpose to give this talk is not to teach you all the classification. You can always go and read up in the textbook, but more to just introduce and to expose to you all some of the classifications that has been used for distal radius. Okay. Oh, I can move it.
Yeah.
Oh, okay. Yeah, okay. All right, so the scope is we'll just review some of the classifications and we'll go through some of the historical ones and then some of the contemporary ones. And then the last part will be mostly talking about a little bit about indications for fixation. So there are more than 20 classification systems that have been devised for distal radius, starting from very long. Right? Eponymic ones are the Coley's type and all that kind, then Gartland and Worley, all the way down to the AO system. Okay, I'm not going to cover every single classification system, just to highlight a few, all right? So these are the eponymic ones. That means these are the characteristic fractures which are given names, right? So the Coley's one, right? Actually, there's another name, Poto, right? The only reason, and then Smith, there's Goyron, all right, Barton, Latournier, all these. The only reason why we don't know these names, although they were actually described a few decades before Coley's and Smith, is because they are non-English. So they never get publicized. But actually these are the people that first described these classical fractures. Okay, then you have chauffeurs and die punch, all right? So this is like a Coley's, all right? Right, dorsally angulated, dorsally displaced with radial displacement and loss of radial inclination. Okay, this is a Smith fracture where it has volar angulation. Right, die punch, right at the radial lunate fossa. Okay, just to show a few. And this is a volar Barton's, right? Partial articular with the volar fracture at the volar rim, and then fixed with a buttress splitting. Not really buttress now, since you put the screw there. Okay, so let's go a bit into the historical classifications, all right? There's quite a number of them, all right? We'll just go through one by one. Right, the first classification that we could find was Distal in 1925. Right, basically he classified distal radius fractures into anterior and posterior displacement. Okay, and then later on in 1938, Taylor and Parsons added on injuries of the TFCC to the classification. Okay, this one is probably one of the more well-known historical classification in 1951, Gartland and Worley. All right, they also have a functional scoring system, but they also have a radiographic classification system. So this is their radiographic classification system. Sorry, I'm blocking you. So their classification system is actually, originally was 3 grades, 1, 2, 3. And then Sogard in 1985 added a 4th grade. And the classification is based on whether the fracture is intra or extra-articular and whether is it displaced or undisplaced. So group 1 is an extra-articular fracture which is displaced. Group 2 is intra-articular undisplaced. Group 3 is intra-articular displaced. And because he didn't have an extra-articular undisplaced, right, that became a group 4. Okay. That was the modification. Actually, by right, you should move it up on top, maybe a group 0. But so now you have a group 4 that actually is better than a group 1. Okay, so this is the Gartland and Worley. All right, the Gartland and Worley, conceptually, you can actually use it to determine treatment and also to prognosticate to some extent. All right, very roughly, right, as you know, any extra-articular fracture that is displaced, any fracture that is displaced, you need to have reduction. Okay, the only question is how much displacement requires reduction. So group 1 and group 3 require reduction. Group 2 and group 4 no need because they are not displaced. And prognosis wise, right, you can say that group 4 probably has the best prognosis and then followed by group 1, 2, and 3. Okay, so this is the Gartland and Worley system. And then Lidstrom in 1959 came up with his own another classification system, a little bit more comprehensive, right? He divided into group 1, group 2, and group 3. So group 1, no displacement of the fracture. Group 2, dorsal angulation fracture, and group 3, volar angulation. So group 2 are like the Coley's type, right? And group 3 are the Smith type, all right? But Coley's fracture, by definition, are not intra-articular fracture. So I just call it Coley's type, but not really Coley's. Oops. And then they divided, So they divided the group 2, because at that time, the dorsally angulated fractures are more common. So they subdivided them into 5, A, B, C, D, E, all right? The subdivisions are based on whether is it articular, right? Extra-articular for A, B is intra-articular, C is extra-articular with dorsal displacement. So dorsal angulation is, am I pressing something?
I think application, just, okay.
Oh, sorry. Okay, so dorsal angulation is different from dorsal displacement. Dorsal angulation just means it's angulated dorsally, but dorsal displacement also means that it's displaced dorsally. Okay, this is just dorsal angulation and this is dorsal displacement. So that's C. D is an intra-articular fracture with dorsal displacement, and E is with articular combination. Okay, so this for Lidstrom's classification. Okay, Lidstrom himself actually did say that if you come up with a classification for distal radius, actually you should base it on a few things. The fracture line, you should be able to tell the direction of displacement that he has. Also be able to quantify the degree of displacement because that affects treatment and prognosis. The extent of articular involvement and any involvement of DRUJ. So even when he came up with classification system, he only was able to base it on these 3 factors. He was not able to account for the other 2 factors. Okay, older classification was in 1965, and this was modified by Surg in 1985. So this is the first semi-quantitative classification for the distal radius. And you're able to assess the degree of displacement of the distal radius. However, this system, although quite good, okay, can only be used for the Coley's type fracture. That means fractures which are dorsally angulated or dorsally displaced. All right. Basically, what they look at is radial height and dorsal angulation. So there's a number of criteria, up to how many degrees of dorsal angulation is 1, right? And then there is 2. 3 is when there's also comminution. And then 4 is for intra-articular fractures. So it seems like Surg likes this classification very much because he has done a couple of papers. And in this paper, he actually shows that there is very high intra and inter-observer agreement for older classification with a couple value of up to 0.7 for inter-observer agreement. And in another paper where he reviewed 269 distal radius fractures, he actually validated that actually this classification does provide prognosis, because he says that based on the outcome of radiography, not functional outcome, okay, based on radiographical outcome, the 3 factors that he found that prognosticate was the quality of the reduction, the older classification system, and the age of the patient, right, affects the radiological outcome. In that study, he also emphasized that when you do reduction, the most important parameter that you need to aim for is to restore the radial height. Okay. Okay, next, Friedman is quite famous. I think everybody knows this. It's very easy to remember. And okay, however, the agreement, inter and intra-observer agreement is not that high based on this GHSE paper in 2007. Basically, it emphasizes whether the fracture involves the radial couple, right, DRUJ, or radial couple and DRUJ. And the even number classifications are those with ulnar styloid fractures. Okay, so now we move on to the contemporary classifications. I'm just going to talk about these 4 classifications: Malone, Rehak, Fernandez, and AO. So Malone came up in 1987, And his classification is only for articular fractures, all right? So he taught us that articular fractures can basically can be thought of as four main parts: radial shaft, radial styloid, medial dorsal fragment, and a medial volar fragment. All right, so these four main fragments. All right, and then his classification is based on group 1, 2, 3, 4, and 5. So group 1 basically is for stable and undisplaced articular fractures. Okay, so that's a Malone one. And then when he says stable, also means that it's stable after you do the reduction, doesn't displace, and there's no comminution. Okay, group 2s, right, is this one. Group 2s are reducible but comminuted, and group 2b is irreducible and comminuted. So usually when they say irreducible, it's because got this fragment that is intra-articular, totally intra-articular, with no ligament attached, so you cannot use ligamentotaxis to reduce it. So that's what he means by a difference between the 2A and the 2B. Right, group 3 has got a spike in front, which comes from the radial shaft. Group 4 is very severely comminuted with either very wide separation or even rotation of this fragment. And group 5 is a type of explosive type of injury. So this is the Malone classification. Okay, then a few years later, Rayhead came out with his universal classification, which subsequently Cooney advertised a lot about it. This classification is treatment-oriented, and in many ways, people feel it's more practical because it sort of tells you what you should do for different groups. And this one actually is based on the Gardner and Worley's, which I showed you just now in 1951. This classification also added the concept of fracture reducibility and stability. Okay, so there is 1, 2, 3, 4. Okay, I think we can go on to here. So basically, there's 4 groups in the universal classification. Group 1, 2, 3, 4. 1 is extra-articular undisplaced. Group 2 is extra-articular displaced. Group 3 is the intra-articular fractures, and 3 is undisplaced, and 4 is displaced. So it's quite nice and neat in that sense. Okay, it's quite similar to Gardner and Worley. Okay, so for group 1, treatment is splinting, right? For group 2, if it's reducible and stable, it's splinting. If it's reducible, unstable, you need fixation. And if it's irreducible, then you need open reduction, internal fixation. Right, group 3, undisplaced, splint. Right, group 4, displaced, depending on whether is it reducible, unreducible, or whatever, you can dictate the different kinds of treatment. All right. So in this way, it's quite practical, and if you use this classification, you can sort of think about what treatment you need to do. It also sort of prognosticates, because obviously, if it's an extra-articular fracture, prognosis tend to be better, whereas intra-articular fractures tend to be poorer in outcome. So by right, although there's this not been validated or done any study, but by right, group 4 should have a poorer outcome than a group 1 fracture. So let's talk a little bit about stability, since the universal classification talks about it. So there are many ways to predict stability, but I think most commonly what we use is the LaFontaine criteria. Right, this is often quoted. And basically there is 5 factors: dorsal angulation more than 20 degrees, presence of dorsal comminution, intra-articular fracture, ulnar styloid fracture, and age. Okay, so basically what it means is that if you have a patient who has more than 3 or more of these factors, the rate of displacement or the instability of the fracture is high. Okay, you can see from this graph that they do. Okay, but of course not everybody agrees. There are some papers who say only age is a factor. Then some papers say radial inclination, shortening, dorsal angle. Right, but whatever the case is, the common finding among all these papers is that age is definitely a predictor for instability. So the older the patient is, the more likely the fracture will be unstable. Okay, there's also a classification for radiographic outcome. For those of you who may not know, right? So there's the Lidstrom score. Right, this is the one that you use to judge whether your reduction is good, and whether the fracture union is good. All right. A lot of people call it stewards, but actually originally it came from Lidstrom, but just that over these years, many people has modified it. And I think most orthopedic trainees know this as steward score, but actually it's Lidstrom. Okay, so based on the parameters for dorsal angle, radial height, and radial angle, right, you can score it. Right, once you add up the scores, right, you can get the grade. So a score of 0 is excellent, and a score of 7 to 12 is considered a poor outcome. So we have done this before, and we used the Lidstrom score, and actually reviewed 48 patients over a 1-year period in patients who are aged 60 years and above for those distal radius fractures which are conservatively treated. And you can see that actually this is the group of patients. I think there's about 48 here. Our residents do quite a good job. More than 90% of the fractures actually considered to be satisfactorily reduced at the time of presentation. But by the time of final outcome at a mean follow-up of 2 years, actually most of them has lost their reduction. So probably about 40%, from 90% to about 50%, with 40% loss, 40% loss in the satisfactory outcome rate. And this is significant. All right, I think, there's something at the bottom here. A bit too low. I think it's, can we move it? Yeah, so basically in patients aged 60 years and above, in our local data, for distal radius fractures treated conservatively, nearly 70% of them displaced during the cast treatment. All right, so age is quite significant. I don't have the below 60 data, so anyway, this is just what we have. All right, so this is an example of a case, 61-year-old male, all right, well reduced, right, based on the Lidstrom score is excellent, right, good radial height, nearly neutral. 8 days, now based on the classification is considered good, no longer excellent, but this really tells you that it's a little bit unstable, right? But I would tell you that most of the time when we see it 1 week, we don't really measure it. So if you don't measure it, you may not know it has become good. So you just look at it and look at the one and say, I think it looks the same. So no problem, put you on a cast, and then you come back 1 month later. And then that's what happens. 1 month later, which is 30 days, poor outcome, everything has collapsed. All right, this is not an uncommon thing. So actually, we find that most of these displacements, 75% of patients who are going to displace will displace before the 4th week. So it's very important to see them during the critical period between the 2nd to the 4th week. So do not TCU 3 to 4 weeks after changing the cast. Make sure you see them 1 to 2 weeks later. Okay, the next classification I'm going to go to is the Mayo classification. This one was developed and supposed to be a subset of the universal classification. So you actually use the universal and the Mayo classification to give it a little bit more resolution. So basically type 1 to type 4. Type 1 is an undisplaced intra-articular fracture. Some people even call type 1s extra-articular fractures. Right. Type 2, right, are any displaced intra-articular fracture involving the radial scaphoid. Type 3, radial lunate, and type 4, radial scapholunate. Okay, so this is just a Mayo classification. It doesn't talk about displacement or anything, it just tells you where the fracture line is. Fernandez came out in 1987 with this classification that is based on the pathogenesis or the mechanism, right? So type 1 are bending fractures, right? Can be volar dorsal. Type 2 are the shearing fractures like the Barton's fractures, right? Type 3 are the compression fractures, which like the die punch, and type 4 are the avulsion fractures. So this includes the radial carpal dislocations or the inferior arc injuries, and type 5 is the combined type. Okay, and finally we have the AO. I think everybody knows the AO quite well. So basically, A is the group, then 1 is the type. Oh wait, sorry, A is the type, 1 is the group and point something is the subgroup. All right. So there is a number that precedes this AO classification. This number 2, 3, right? For you all to understand, right? Refers to 2 refers to radius and ulnar, and 3 refers to the distal end of the distal segment. So 2, 3 refers to distal radius fractures and distal ulnar fractures. So 2, 3, A1, right? Not of concern here, since you're talking about distal radius, because 2, 3, A1 refers to ulnar fractures, right? And 2, 3, A2 are extra-articular fractures, which are simple, and A3 are comminuted. All right, so then you have all the subgroups, right? 2.2 is actually like a dorsal fracture, and A2.3 is a volar tilt fracture, okay? And then A3 are the comminuted extra-articular fractures. All right, this is a case A3.3 for ulnar head fracture, right? Extra-articular with some comminution. Right, B1 partial articular fractures. So you have the Schoeffer's type of fractures, and then you also have the medial fracture. B2 is the dorsal buttons, and B3 is the volar buttons. All right, and depending on what the fragment is, if the small fragment is 3.1, 3.2 for single large fragment, and 3.3 comminuted. And C's are all the articular fractures, right? C1 is simple articular, simple metaphyseal. C2 is simple articular, complex metaphyseal. All right. This is an example of a C2.1, right? Articular fracture with a comminuted ulnar neck and head fracture, very displaced. And then we fixed it with a 3-plate system, and quite a good outcome. And then C3 is the worst with all the complex articular and complex metaphyseal segment. Okay, so just want to show the AO system can be used to look at the type of fractures. So this is the distribution of our distal radius fractures that we see in a tertiary hand center in SGH. Basically, you can see that, like what our guest speaker has mentioned, we see a very high percentage of type C fractures, 40% versus 20 and 20. So I think orthopedics get most of the A's and B's too. Yeah, and in our series, 76% of our distal radius fractures have other bony injuries. So they are just not a simple, straightforward distal radius fracture. So there are a total of 88 other bone fractures. Ulnar styloid is the most common, obviously. Some of them has some finger fractures. For the carpal bone fractures, scaphoid is quite common, 11. Right, that's nearly, I think nearly 10, 11%. And then 10 ulnar head, neck, and shaft fractures. These are non-ulnar styloid. That means they are significant fractures of the distal ulnar. And then some of the other fractures affected are the triquetrum, capitate, and lunate. And then we also find that there's a tendency that for a more A, B, and C fractures tend to have more associated fractures. It's just that we have a very low sample size. I think it's only 1 or 2 for B1, so that's why we have 100%, but actually seems to be a trend towards multiple fractures in the higher classes for the AO. So after I talk so much, what classification should you use? So based on the IFSSH Bone and Joint Committee meeting in 1992 and 1995, they were trying to find a consensus on which classification system they should adopt. But after talking for a long time, they couldn't decide, and basically they just said that there's 3 finalists, Rehag, Fernandez, and Mueller AO. So there is no one classification system that we can really use. So it's really up to you. And Jesse Jupiter did a study, and they reviewed 36 orthopedic or hand surgeons, and this is the frequency, right? 8% of the surgeons use AO, 42% use Friedman, and 16% use universal. And 1/3 of them don't use any classification system. So if you don't use, I guess you're okay. Yeah, this is from Jesse Jupiter in Canada. I think he was doing his fellowship then or something. Okay. Okay, so now we'll go on to indications for fixation. There are many indications for fixation. It really depends a lot on cultural factors, social factors, financial factors, and stuff like that. But for me, when I want to give this talk, I want to give it so that the residents understand some principles. So I will just distill it down for you. Actually, there is only one indication for fixation, right? The only indication is when non-surgical methods are not able to hold a fracture. That's the only indication, all right? All the other indications are quite soft in a sense, okay? But anyway, generally when we talk about indications, there is two groups, patient factors and fracture factors, okay? So obviously, patient factors are like patient's age, right? The health of the patient and the functional demand. For fracture factors, you think about it in two ways, largely. All right, there are other ways, like for example, open fractures and all that kind of stuff. But I don't really consider that, because if you really want to be picky, right, open fractures doesn't mean that after you debride you have to fix it, but we fix it anyway since you are there. Okay, but if you're talking about very academically, fracture factors is deformity and stability. Okay, so in other words, a very deformed fracture, right, generally needs fixation, right, because you need to reduce it. Right, actually, you just need to reduce it. Right, so deformity you look for is radial shortening, radial inclination, dorsal angle, step off, gap, and ulnar variance. The reason is because if you don't correct all these things, they will get osteoarthritis, or they may have DRUJ problem, and they cannot have forearm pronation and supination. So let's see. So when you have radial shortening and radial inclination, what happens is that actually, your thing will tilt this way, and then you have increased the pressure at your radial lunate, and you have some loss of congruency at the DRUJ. So this causes radial carpal arthritis and maybe DRUJ problems. Okay, dorsal angle, if you tilt your distal radius too much, you have incongruency at the DRUJ, and you may have carpal malalignment. This is the maladaptive carpal malalignment with DC. Of course, step off and gap, right, causes increased articular pressure, and ulnar variance, right, causes ulnar impaction. So these deformities generally need to be addressed. So the question now is how much, right? So these are the numbers based on some papers, right? So if your radial inclination is less than 15 degrees, right, you should do something. Your radial height is less than 5 millimeters, or ulnar variance is more than 2 millimeters, or dorsal angle is less than 15 degrees, or volar angle is more than 20 degrees, or any step off of gap of more than 2 mm. This is the so-called accepted parameters for treatment. Okay. All right. What about stability? So this, you can use Lafontaine's criteria, or you can use this is by Jupiter. Okay. So he says that if you see dorsal comminution more than 50% width of the distal radius, there is palmar metaphyseal comminution, or if the initial deformity is severe, right, and that is with dorsal tilt of more than 20 degrees or displacement of more than 1 centimeter, articular fracture, associated ulnar fracture, osteoporosis or advanced age. These are all factors that indicate the fracture may be unstable. So a little bit about ulnar styloid fractures and fixation. I think more than 10 years ago, there are people who say that you must fix all ulnar styloid fractures. All right, now we know it's not true. Okay, ulnar styloid fractures no longer need to have fixation. All right, but you need to evaluate it. Right, after you fix your distal radius, then you check for DRUJ stability. If it's stable, that's it, end of surgery. If it's unstable, right, but your DRUJ is reduced, you can either just splint it, or if you want, you can fix it. But if it is subluxed, then I think you have to fix it, KIV, KY, the DRUJ. Okay. So anyway, this is a Mayo Clinic paper. Say that people who fix distal radius fractures should be familiar with the evaluation and the treatment of these ulnar-sided injuries. Alright, this is quite interesting evidence. After I talk all this to you all, I hope by saying this I won't confuse. But this is Kevin Chung's paper where he talks about some myths of distal radius fractures. So this is a myth. Distal radius fracture classifications have practical value. That's a myth. The reality is they are complex and non-standardized. They lack intra-rater and inter-rater reliability, and they lack prognostic information. So maybe that's why 1/3 of surgeons don't use it. Alright, and the other thing is anatomic reduction is necessary for good outcomes. It's not so clear. Some people say it does, some people say it doesn't. So this is to them considered a myth. Alright, so this is just to show that basically to be good you need to be about 0.6 for the kappa agreement. So you can see most of these inter-observer agreement is all very low, 0.45. In other words, that means let's say I grade the fracture, then I ask another surgeon to grade it, right? More than half the time we won't agree, okay, what the grading is, right? But Cooney's group in this is about 0.59, it's not too bad, but that's intra-observer, okay, the inter-observer. The other thing is intra-observer, that means I ask you to grade now, and then 2 months time I give you the same x-ray, ask you to grade again, right? You won't even agree with yourself 100% of the time. So about 50% of the time you will be disagreeing with what you initially graded. So you can see most of the inter-observer reliability is at best moderate, right, for Mayo and Friedman. The rest is just fair or fair to moderate. Okay, Jesse Jupiter did this, I think, and no, this is not Jesse Jupiter, this is another guy. Right, again, quite low, right, universal 0.4, AO 0.27, Friedman 0.24, Fernandez 0.234. So the higher the number, the better the agreement. Yeah, this is a Jesse Jupiter paper, right? Able to get up to 0.68 for type. Type is only the letter, right? That's like only A, B, or C. So very high. Of course, anyone can see whether it's extra-articular, partial, or intra. But when it comes to group, it's 0.48 and 0.33. So even in this, there is not much agreement. So in summary, okay, I think just use, if you want to, at most 1 or 2 classification systems, and then one of the 3 recommended ones will be fine: AO, Rayhack, Universal, or Fernandez. And I think for exam purposes, maybe you should be familiar with the classics like Friedman and the economic classification. And just know that up to now, we still do not have the perfect classification system, all right? And then for indications, know what amount of deformity is acceptable. Know your predictors for stability, like such as age and various radiographic parameters. And know that we are still do not have all the answers, and we are still doing research on distal radius. Okay, thank you.